Hello, I'm Jeremy Pomeroy. I'm a research scientist at the Marshfield Clinic Center of Excellence for BBS, and I'm happy to be speaking today to provide an update on the clinical registry investigating Bardet-Biedl syndrome, or CRIBBS, for the Family Association Virtual Conference of 2022. I want to start off with a disclosure. I've received research support from Rhythm Pharmaceuticals. I'll be talking a little bit about some of that research today, and so I just wanted to disclose the support. CRIBBS is the largest registry examining the long-term health of individuals with BBS. We're over 715 participants in CRIBBS now, and we've conducted over 2,600 interviews in people from over 40 countries. The interviews include an annual health interview with a research coordinator, and we also ask participants when they are able to share electronic health records. The CRIBBS team here, besides myself, and I'm the principal investigator, include Debbie Johnson. She's a research coordinator and CRIBBS interviewer. I'm sure many have spoken with her. And then more recently, Nellie joined us. She's also a research coordinator. She's bilingual. She does interviews in both English and in Spanish. And as I said, she's also a CRIBBS interviewer. And then someone that doesn't really get the opportunity to talk to participants is Jesse Richardson. And I want to highlight the important work that he does. He's the project manager for us, and he's a CRIBBS analyst. And what he does is he does all of the background work to make sure that the interviewers are able to conduct their interviews seamlessly and going through the questions and not have to take a lot of time between questions and so on, but still capture the data that is being provided by the interviewer and the participants in a way that then scientists like myself can use it to help improve health and well-being of people with BBS. There's some other components of the BBS Center of Excellence at Marshfield Clinic that I want to bring up. First, we have multi-specialty clinics for adults and children with BBS. Patients travel here from throughout the United States and around the world to receive care at these multi-specialty clinics. We have CRIBBS, and then we also do clinical research, including clinical trials. The reason that I want to bring those other components other than CRIBBS up is because I think they form what I call three pillars of care. The clinical care, CRIBBS, and the clinical trials, they combine to make each more valuable. For example, the registry makes us an effective partner for clinical trials. I mentioned Rhythm at the beginning. A few days ago, Rhythm Pharmaceuticals received FDA approval for setmelanotide, now also known as IMCIVREE, for chronic weight management in people with BBS who are over the age of 6 and struggle with obesity. And often in rare disease research, one of the challenges for clinical trials is finding patients, and the registry obviously completely resolved that issue. I'll talk a little bit more about some of the ways that the registry makes us an effective partner for clinical trials a little bit later. Also, by providing the multi-specialty clinics, the research findings, like the things that we discover in CRIBBS, can be much more quickly disseminated to clinicians seeing patients. And that not only is in terms of our communication with the clinicians in our multi-specialty clinic, but they also provide feedback to us to help make the message more impactful when we're communicating with clinicians who are not part of the Marshfield Clinic system. And then additionally, clinicians who see patients so often as they do in our multi-specialty clinics, they'll identify research questions for us. And sometimes it turns into an actual manuscript, and other times it's just something that helps them provide better care, where they might see an issue in a few patients and ask if that is something that's common in BBS, and CRIBBS is an excellent tool to answer those types of questions. Now, one of the things that I think is also very important to bring up about the BBS Center of Excellence at Marshfield Clinic is that, as I think most are aware, Dr. Hawes was the one who started this, and this was really his dream. And he recently retired, and we're sad to see him go. But I also just wanted to talk about the work that he did when he was here and during his transition to retirement to make sure that the BBS Center continues to basically try to honor his vision. So, and this is also one of the ways that these three pillars work together to provide better care. So we have now a leadership team at the BBS Center of Excellence, and it's composed of clinicians, Dr. Offenwanger and Dr. Okori, who do see patients in our multi-specialty clinic and also do participate in research. Myself, as the research scientist responsible for CRIBBS, and then Sonia Suna, the clinical coordinator, who manages the visits that people come when they come for our multi-specialty clinics. And this leadership team working together helps to make sure that those three pillars, that there's good communication between those pillars. So now what I would like to talk a little bit about is some recent important findings from CRIBBS. And these are some papers that were published over the last few years. So first, we discovered that overweight and obesity develop in the first 2 years of life. And I'm going to talk more about each of these papers in a few minutes. We also found that insufficient sleep is very common in both adults and children with BBS. And then the last is the most recent paper as well, which is that kidney failure poses a significant risk for premature morbidity in people with truncating variants and disease-causing variants other than the BBSome and chaperonin-like proteins in BBS. So first, in 2020, we published a paper looking at weight patterns and genetics in BBS. And the way that we did this was using CRIBBS. We had BBS genotype and height and length and weight measurements during childhood. And these measurements included from the medical records that patients sent us, as well as from the self-report from health interviews. Every health interview, either Debbie or Nellie will ask about recent heights and weights, and that gets recorded into CRIBBS. And then the BBS diagnosis was supported by genetic testing in 385 CRIBBS participants. So what I want to focus on right now is what we discovered about overweight and obesity in pediatric patients with BBS. And so the slide that I'm showing has, it's one of the tables from the manuscript. And it shows a lot on it, and I'm just going to highlight a couple of important things. So first, using the WHO child growth standards, because, and I want to focus on that rather than the one on the bottom, the IOTF, because it includes from birth. But what we found is that even among children under the age of 2, overweight or obesity was common. Only 44 or about 45% did not have overweight or obesity. And then as in the older age groups, overweight and obesity became much more common. And then highlighting over here, the obesity specifically, that for participants aged 2 to 5, about 60% had obesity. And then from 6 to 11, about 83%. And then 12 to 19, about 77% had obesity. So, this is important characterization of the obesity patterns, the weight patterns in people with BBS. Some other things from the paper and some conclusions. Birth weight and length tend to be appropriate for gestational age. And this is important for a couple of reasons, but one is that this helps, as clinicians understand this better, it helps to distinguish between potentially different rare diseases in which childhood obesity is a common feature, because there are other rare diseases where birth weight might not be as appropriate as what we see. But then we see a rapid onset of overweight or obesity in early childhood, which persists through adolescence, and not so much from this paper, but we know it persists into adulthood. And so a conclusion from this is that interventions to benefit weight management should be offered as early as possible in people with BBS. The next paper that I want to talk a little bit about is one looking at sleep and physical activity patterns in adults and children with BBS. So we did a study where we asked participants from CRIBBS to wear a device on their wrist that is kind of a research version of a Fitbit. The device, it's called the Actigraph Link. Participants older than 3 years of age and living in the United States were eligible to participate. The participants were mailed one of these Link devices to wear for 12 days. Then we included an addressed postage-paid envelope for them to return the device to us so that we could then download the data. And one of the most important findings from the paper was about meeting sleep recommendations. Every age group has recommendations for how much sleep to get. It's usually a range, let's say, for example, from 7 to 9 hours. And so we wanted to know how many people, both children and adults with BBS, were getting that, falling within that recommended range. And the results were striking. So what I've highlighted on this table that I'm showing here is that only about 10% of adults met their sleep recommendation for age, and only about 8% of children met the recommendation for age. And one of the things, it's possible to fail to meet the recommendations by either not getting enough sleep or getting too much sleep. But what we found is that it was almost exclusively people not getting enough sleep. And this is something that's very common in a lot of different people in the United States and throughout the world of not getting enough sleep. It's something I think that almost all of us could identify struggling with. But the fact that it's almost the rule in BBS is important information to learn. Then one of the other things is, as I mentioned, that the device that we used was somewhat similar to a Fitbit, but designed more for researchers. And so what that did is, like a Fitbit, it enabled us to not only understand how people were sleeping, but also physical activity. And so we looked at a couple of different physical activity in a couple different ways. One of the ways that we looked at physical activity was actually the absence of physical activity, or what's called sedentary time, and that's doing behaviors like sitting. And I looked specifically at sedentary time in prolonged bouts, so bouts of 20 uninterrupted minutes of something like sitting at a time, because we know that longer periods like that at 20 minutes have more negative health consequences than just sitting for 5 minutes at a time with movement. And then we also looked at just the total level of activity, which isn't just whether or not someone's moving or not, but how intensely they're moving when they are. I want to focus here, though, on the relationship between prolonged sedentary time and the total amount of sleep. And first, what I'm showing now is the relationship between these two variables in children aged 6 to 12 years of age. And what we see is that there's a significant relationship where children who sleep less, tend to be sedentary more. We also did see in this age group that children aged 6 to 12 who were more physically active tended to sleep longer. In children aged 13 to 18, so teenagers, we saw, just like with the younger children, a significant relationship between total prolonged sedentary time and the total amount of sleep, where, again, just like with the children aged 6 to 12, the teenagers who slept less tended to be sedentary more. We didn't see the same relationship with the total physical activity in this group. And then in adults, again, just like the children groups, both groups of children, we saw that there was a significant relationship between prolonged sedentary time and total sleep time. The relationship wasn't quite as strong in this age group, but it was still statistically significant, where, again, the adults who had the least amount of sleep tended to also be the most sedentary. So just to emphasize, the total prolonged sedentary time was related to sleep duration in all age groups, that the people who were the most sedentary tended to get the least amount of sleep, and it can be said the other way as well, that people who got the least amount of sleep tended to be the most sedentary. In other populations, these bidirectional associations have been observed, and what I mean by that is that someone in other populations, when they see people who someone who gets a poor night of sleep and doesn't get a lot of sleep, tends to be more sedentary the next day, and vice versa. Someone who is very sedentary in a day tends to get shorter sleep the next night. One of the things that this tells us is that interventions that target sleep hygiene, that are aimed at improving sleep duration, and also combining that with an intervention that is trying to reduce prolonged sedentary time, may be the most effective approach rather than just focusing on one or the other. The last study that I want to talk about was just published earlier this year, and it's about a topic that I think is of key importance to a lot of patients and families with BBS, and that's looking at kidney failure. So in this study, we looked at kidney failure as individuals who were meeting the established diagnostic criteria and or genetic confirmation for BBS. So this is people from CRIBBS. And kidney failure was defined as the irreversible loss of kidney function with an estimated glomerular filtration rate of less than 15. And that's consistent with stage 5 chronic kidney disease. So these are the people for whom the need for dialysis or kidney transplantation is imminent. So when we did this study at that time, we had 607 people enrolled in CRIBBS, and of those, 44, or about 7%, had end-stage kidney disease. So one of the first things that I want to show is looking at kidney failure and death. So what I have as a slide here is a figure that has grouped people into whether they had kidney failure or did not have kidney failure, and then plotted what percent were deceased at different ages. And so what we see is that people without kidney failure at age 50, only less than 5%, only about 3% were deceased. Whereas by about age 35 of the people who had kidney failure, about 30% were deceased. So this tells us that kidney failure is a leading contributing cause of death in BBS. We also wanted to understand more about who with BBS is more likely to develop kidney failure. And so I think most people are familiar with the various BBS genes, BBS1, BBS7, BBS10, and so on. But there's a couple of other ways to look at BBS genes as well. And one is to look at the variant type. And so there are basically 3 different combinations of variants that someone can have. And so on the left side, I'm showing all people with BBS for whom we know about their variant types. And so about 37% have what's called 2 truncating variants. About 35% have what's called 2 missense variants, and then the rest, about 28%, have one of each, one missense and one truncating variant. When we look at just the people with kidney failure, the distribution is quite a bit different. What we see is about 68% of people who have kidney failure have 2 truncating variants, and only about 14% have 2 missense variants, and only about 19% have one of each. So this tells us that 2 truncating variants are a risk factor. Another way to look at BBS genes is to look at the gene group. Most people, BBS genes fall into one of 2 groups, the BBisome or a chaperonin group. And then there are some who don't have, it doesn't fall in either the BBisome or the chaperonin. And so there we called just that other BBS group. And so we grouped people by their gene group and plotted on this figure the percentage of people with kidney failure and their age in years. And what we see is that it's the other BBS group that has the highest percentage of kidney failure. That by around age 20, about 60% have kidney failure. Another important finding from this, and something that you're going to be hearing more about in the coming years, I think, as we look at this more, is that we have a new candidate gene for BBS. TTC21B encodes a member of the TTC21 family. Biallelic variants in TTC21B have not previously been identified in BBS, but are associated with other ciliopathies and renal disorders. So, in conclusion, TTC21B is a new candidate gene for BBS. This is an important discovery in and of itself, but in context with its relationship to kidney disease, it makes it even more important to understand more about this gene. Other risk factors for kidney failure include truncating variants, non-BBSome and non-chaperonin genes, and then also we observed that the female sex is also a risk factor for kidney disease, for kidney failure. After talking about some of the things that we published recently, now I want to talk about some projects that we're working on. There's the first two, the community survey of impact of BBS on quality of life, and a study looking at hyperphagia are both, we have manuscripts that we're getting ready to submit probably in the next month or so. And then we've got a project underway looking at unmet medical needs for people with BBS. That project is being done in collaboration with Rhythm Pharmaceuticals. We're also working on developing a guide for the standards of care for BBS. And then just kind of one of the things that's an ongoing process, but we're working more on actually formalizing a way to foster collaboration among scientists and clinicians who are interested in working in BBS. So first I'm going to talk a little bit about the community survey and what's been found. This survey was supported in part by Exovia Therapeutics and then also by donors from the Center of Excellence for BBS. The survey was designed as a high-level, broad snapshot of the diagnostic pathway and life impact of BBS. There were 207 individuals with BBS who were identified in the CRIBBS registry. The participants were people with BBS 1 or BBS 10, and then had a valid email address so that we could contact them, and then could read, write, and respond to a survey in English. The survey covered topics of BBS patients' basic demographics, their diagnostic journeys, aspects of their clinical care, and their impact on life. The key takeaways from this is probably something that's not a surprise to patients and families with BBS, but that I think is going to be an important message for clinicians. And that is that supportive care for families should be an integral component of the management of BBS for patients. That it's important for clinicians working with families who have a BBS diagnosis to consider the overall burden of the diagnosis on the entire family unit and not just treat and manage the symptoms of the family member diagnosed with BBS. I mentioned previously the FDA approval of setmelanotide or IMCIVREE for people with BBS. And one of the ways that this drug works is by targeting hyperphagia. And so as we were working on these studies, and in part due to the feedback that we've gotten from patients and families with BBS, we undertook a project that we wanted to really understand more about the complexity of hyperphagia for people with BBS. And so what we did is we used a questionnaire that was originally developed for another rare disease of which hyperphagia is a component, called Prader-Willi syndrome. This questionnaire has 11 items. It uses a 5-point Likert scale to assess the preoccupation with food, as well as hyperphagic drive, behavior, and severity. This was administered to the patients or caregivers of someone with BBS in the CRIBBS 4th and 6th health questionnaire. The hyperphagia scores by age group was one of the most significant findings from this paper. We found that the youngest participants, who were in the 5 to 8 year range, had the highest scores almost across the board. Their total score, their behavioral subscale score, and their drive score were all higher than the other age groups, and that the scores tended to decline with each age group. The exception was severity, where we did see significant differences between age groups, but it wasn't in a stepwise pattern by age. The other important finding with this is to actually delve a little bit deeper into the relationship between hyperphagia questionnaire scores and BMI or BMI-Z score for younger children. So I have a table here that shows the relationship between the total score, the behavior subscale score, the drive subscale score, and the severity subscale score, and either BMI-Z score for the participants age 18 and under, or just the BMI for people over the age of 18. First, in children in under 18, we found that the BMI-Z score was significantly correlated with every total and subscale score. That people with higher scores, indicating more pronounced hyperphagia, had higher BMI-Z scores. It wasn't so much the case with adults. With adults, the only significant relationship was with the severity subscale score. And again, adults with higher subscale scores also tended to have higher BMIs. So, as I said, we saw this strong negative relationship between hyperphagia score and age. And in children, the BMI-Z score was significantly correlated with all the hyperphagia scores. One of the things, and I mentioned before about the collaboration between clinicians seeing patients and the research that we do in CRIBBS, and this is an example of that, because two of the clinicians involved were dietitians. One was the dietitian here at the Marshfield Clinic BBS Center for Excellence, Tammy Timler, and the other is Sarah Flack, who works in the UK with patients with BBS. And both reported that the results that we found were consistent with the experience that they've had in treating people with BBS. It's not clear yet why younger children seem to have more pronounced hyperphagia. And I also just want to point out, this does not mean that older patients with BBS do not have hyperphagia. They do, it's just not as pronounced according to the hyperphagia questionnaire scores. But we are planning to look more into this to understand why we see what we see and to understand even more about the complexity of hyperphagia in people with BBS. The last thing that I want to talk a little bit about is developing a standard of care guide for people with BBS. There's the frustration with the lack of expertise of medical providers is a very common issue that's raised among patients who are coming here for the multi-specialty care, for people participating in CRIBBS, or when I've actually been able to meet with people at conferences such as this one. The providers that we have here in the multidisciplinary clinics, combined with CRIBBS, are a very valuable resource to understand care needs for people with BBS. That the combination of their clinical experience, as well as with the data that we can use to better understand their clinical experience, is incredibly helpful. The goal for this standard of care is to help patients and families, as well as medical providers for whom they seek care, to understand what to prioritize, what issues to be aware of and to look out for. And so we plan to use this project to produce a couple of different things. One is a journal article that we will submit that will then be accessible to clinicians, scientists, and so forth. We also plan to create a care guide that families can use to understand schedules for receiving care and what tests to seek when and under what condition. I look forward to sharing more about this as it is developed. I just want to finish up by providing some contacts. First, my own email address. If there are any questions that have arisen during the process of viewing this presentation, or if there's anything that anyone feels is important for me to understand or know, I hope you feel free to reach out to me and email me at this address. I also want to share this email address for the Marshfield Clinic Center of Excellence for BBS. This is a way to reach out to us for really any BBS related question. This email is sent to this address, then will be distributed to whomever we feel can best respond. We'll be happy to hear from you, so please don't hesitate to reach out. Thank you for viewing this presentation. I hope that it's been informative and that you have a greater understanding now of the many exceptional things that we've been able to accomplish with CRIBBS. And I also just want to acknowledge how important the support from the BBS Family Association is in CRIBBS and what a successful collaboration it's been.